three wonderful speakers, and thank you to our chair, Dr. Bhuchandran, for getting us through this session. Thank you. I would like to invite onto the stage Dr. Krishna Prashanti and Dr. Anand Moses to take over chairing the next session. We have a potpourri, a diverse set of topics for the next session. So Dr. Krishna Prashanti and Dr. Anand Moses, all yours.
Good evening, everybody. And now we are moving on to a very important session, thematic symposium, associations and complications of the diabetes. In this symposium, I will invite the first speaker, Dr. V Ramasubramanian, to speak on infections in diabetes, usual and unusual. As speaker wants to go early, I request the audience after this session to kindly pass on questions related to this topic. So we know that diabetes is a pan-metabolic disorder with increased incidence of variety of infections day in and day out, starting from urinary infections to the rhinocerebral mucormycosis. We are going to hear to our learned speaker, who is a consultant of infectious diseases from Apollo Hospitals, Chennai, and he has vast experience in treating all the newer viral epidemics too. Over to the speaker.
Thank you very much, chairpersons. I've been asked to talk to you over the next 20 minutes on infections in diabetes, usual and unusual. And I'm going to present about 5 cases, very brief cases with a lesson to learn from each of them. The first case is a 67-year-old diabetic. He presents with recurrent episodes of fever, chills, and dysuria. In the past, urine routine has shown pyuria, and urine culture has shown the growth of E. coli in significant colony count. He has had several courses of antibiotics, and the ultrasound this time or recently done was normal. Creatinine is 1.1. What next? Now, I'm going to just show you 5 questions this case would provoke, and I would like to discuss the answers. The first question is, would you send a urine culture in this patient? How many of you feel that we should send a urine culture for this patient? I see one hand there. I see a few hands coming up. Let me put it this way. How many people feel you need not send a urine culture for this patient? Yeah, a couple, yeah. Tentatively. Right. So the lesson, even though in the West, the recommendations are for uncomplicated cystitis, no routine urine culture is necessary. In India, where we have a high level of antimicrobial resistance, whether it is a complicated UTI or an uncomplicated cystitis, please always send a urine routine and culture before initiating treatment. You don't need to wait for the result, but send the cultures off before you start treatment. And this, I think, should be a dictum for all patients because of the high level of resistance and especially the useless indications for quinolones in urinary tract infections with a susceptibility rate of about 20 to 25% warrants that we send a urine culture for all patients. And please remember that the urine culture should always be accompanied by a urine routine. Never send a culture in isolation. The second question, what empiric antibiotic would you start? Now, please remember this is a complicated urinary tract infection. I told you this patient has fever, chills, and dysuria. So this is not an uncomplicated cystitis where the person has only some dysuria and frequency. We are talking about fever and chills. So this would make the possibility of a pyelonephritis very high. So what empiric antibiotic would you start? Please don't start quinolones. That's the answer to this. Quinolones are worthless as empiric therapy. The general dictum for starting empiric therapy is that it should at least cover 90% of the probable pathogens in both choice and susceptibility pattern. So which means somebody presenting to you with a pyelonephritis in India would inevitably require parenteral antibiotics. This could be either carbapenems or a beta-lactamase inhibitor because the occurrence of what we call as extended spectrum beta-lactamase producing gram-negative bacilli. These are E. coli and Klebsiella, which produce an enzyme which will knock off all your third-generation cephalosporins. So you need to give antibiotics broader than that, which will inevitably be either carbapenems or a beta-lactamase inhibitor parenterally as empiric therapy till you get the culture reports. This would be the suggestion. 3, how long would you treat? All case of Complicated urinary tract infections require at least 10 to 14 days of treatment. Do not give 3 days and 5 days, even if the patient responds. Recently, there have been some articles where when you use quinolones, you can probably use a shorter duration of therapy. Maybe 7 days would suffice. But as I told you, quinolones reach very high concentrations in the urine, but the susceptibility pattern is so abysmally prevalent that generally when we use beta-lactams or carbapenems, 10 to 14 days is what is advised. Question 4, would you repeat a urine culture after treatment? How many of you feel that we should repeat a urine culture in a person who responds well to treatment? Now you start this patient on, say, cefoperazone sulbactam, the patient responds, the culture comes back as an ESBL, you give 10 days or 14 days of cefoperazone sulbactam. How many of you feel that by day 15 you need to repeat a culture? I see a couple of hands, few hands going up. No, there is no rationale to routinely repeat a urine culture in a person who has responded well clinically to treatment. The reason being, the latest guidelines on asymptomatic bacteriuria were available about a couple of months ago, and asymptomatic bacteriuria refers to a patient who is asymptomatic but is having a significant colony count of bacteria, probably associated with pyuria. Routine antibiotic therapy is not indicated for asymptomatic bacteriuria unless you are treating a pregnant patient. So, routine culture in a person who responds well and to whom you have given an adequate duration of therapy is not routinely warranted. You may try if this person has repeated urinary infections, but otherwise for one episode of complicated UTI, you treat appropriately, he responds, you don't need to repeat it. So I'm giving a lot of provocative points here. 5, how would you manage recurrent infections? This is more commonly seen in women, especially a 50, 55-year-old postmenopausal diabetic comes with recurrent urinary tract infections, both uncomplicated and sometimes complicated with presence of fever and chills. How would you manage? Now, you need to remember that when you are approaching a person who has recurrent UTI, the first thing is to confirm the diagnosis. If they have had a couple of episodes in the past, you tend to assume that this episode with fever could also be a complicated urinary tract infection. So always repeat a urine routine and culture and confirm the diagnosis and rule out other causes of fever. 2, it is very important to image the person. I will just quickly show you the next slide. This slide shows a very bulky right kidney, suggestive of a pyelonephritis. So it is important that you need to image to confirm the diagnosis and also sometimes to define. For example, an ultrasound may show a hydroureteronephrosis. Unless you relieve the obstruction, your person is going to get repeated infections. As you all know, diabetics are at an increased risk of papillary necrosis. So a lot of times they may have a necrosed papilla which may be hiding somewhere, which may be visible only by a hydronephrosis, or sometimes a CT scan may reveal a filling defect. So you need to look for evidence of papillary necrosis. You may need to do a urodynamic testing, again, especially in women, because a lot of times postmenopausal women with urethral strictures may have an obstructive symptom which may contribute to the recurrent urinary tract infections. You need to look at it and sort it out. Always determine the site of infection. Is it pyelonephritis in males? Could it be prostatitis? Pyelonephritis, 10 to 14 days treatment will be adequate. Whereas if the person has a prostatitis, he may require 6 to 12 weeks of treatment. So you need to know where the infection is to decide whether you have inadequately treated the patient and that's why he's getting repeated infections. Give the appropriate treatment based on the culture. Treat structural abnormalities, and only if it is a true recurrent infection, when you have ruled out both structural and functional causes for a complicated urinary tract infection, would you think of a chronic prophylaxis, otherwise not. Okay? We move to the second case. A 40-year-old businessman from Kadalur. He is a diabetic with an HbA1c of 10.8, presents to you with a 2-week history of fever, cough and scanty expectoration of 10 days duration. On examination, you are not able to find anything. He's already had 2 or 3 courses of antibiotics, including beta-lactamase inhibitors, including ceftriaxone and doxycycline. He's not responding. X-ray shows a patch in the right lower zone. What next? So this appears to be a pneumonia in a diabetic patient who is probably being given carbapenems also, not responding. What do you think? Tuberculosis, yep, possible. His white cell count is 25,000. CT of the chest. There you are. The CT shows the right lower lobe pneumonia. Okay, I will give you another clue. While doing a CT, the radiologist finds that there is a lesion in the spleen. So he goes ahead to do a splenic CT abdomen also, and then this shows a splenic abscess. Melioid, excellent. So the blood culture and the sputum culture grow a non-fermenting gram-negative bacilli with this pattern. So this is Burkholderia pseudomallei. We are seeing more and more and more of this. Even though we specifically looked for it earlier only in patients with uncontrolled diabetes, we are seeing it even in healthy patients now. I recently had a 30-year-old patient with no comorbidity with a fulminant melioid. So please think of melioidosis. We are seeing more of this, and unless you get the treatment right, the treatment involves either carbapenems or ceftazidime as the initial parenteral choice for at least 2, sometimes 4 to 6 weeks in patients who may have bone or joint involvement. It is generally transmitted by inhalation, ingestion, or it can also be percutaneously inoculated. Uncontrolled diabetes, alcoholics, patients with chronic renal disease are more prone. It causes a subacute to a chronic pneumonia, and sometimes they may also present with arthritis and multiple osteomyelitis. Septic shock with visceral abscesses can happen. Treatment, as I told you, the choice is either meropenem or even better, ceftazidime. 2 grams 6th hourly is what is recommended for an adult. You may need to give at least 2 weeks of initial therapy for such patients, and then they may require another 5 more months of treatment. Please remember, for Burkholderia pseudomallei melioidosis, treatment may go 5 to 6 months. So after the initial therapy, you need to give either cotrimoxazole or doxycycline. So one of them, whichever you fancy, for another 5 months is what is recommended. So please remember this. If you do not treat it adequately, they will come back in a matter of a few weeks. So this is something all of you need to keep in mind. The third patient I saw about 3 weeks ago, a 59-year-old male with, again, a HbA1c of 8.9, presented with a fever of 2 days duration, sudden onset of dizziness and drowsiness. They thought it was hypoglycemia. The CBG was 224. A chest X-ray was done, and the chest X-ray showed, can you see this? There is a, oh, you're not seeing anything on this. Okay, you can see a right upper zone. There is some, infiltrate in the right upper zone. I don't know, I'm able to see that in my, the arrow is coming on my slide, it is not coming there. Okay, so his white cell count is high. So this is a patient with an acute community-acquired pneumonia. What do you think it is due to? What is the commonest cause of community-acquired pneumonia, especially in a diabetic? Strep pneumoniae, or otherwise called pneumococcus. Please remember that in patients with diabetes, they are 6 times at a higher risk of developing pneumococcal pneumonia than a healthy non-diabetic person. And they inevitably present quite fulminantly. They present with acute fever, breathlessness, sometimes they even with septic shock. So you need to understand that the commonest cause is pneumococcus. Fortunately, in India, most of the strains are penicillin sensitive. So good old penicillin, cefuroxime, ceftriaxone, coamoxiclav are acceptable. You don't need to give carbapenems, you don't need to give vancomycin, you don't need to give anything stronger. So such patient who may require admission in the ICU very well responds to ceftriaxone. This patient responded. We couldn't confirm it was strep pneumonia. It is difficult to culture. But please remember, patients with diabetes, especially who have had a pneumococcal infection, require vaccination to prevent further episodes. It is recommended that you see the column on the left. Anybody who's 19 to 64 with chronic conditions like diabetes requires only 1 dose of a polysaccharide pneumococcal vaccine. Pneumovax 23 is all that they require. A conjugate Prevnar 13 is not indicated if there are no other comorbidities and the person is under 65. The other columns show for elderly people above the age of 65 require a conjugate followed by a polysaccharide in 1 year. If they are immunosuppressed, a conjugate followed by a polysaccharide after 2 months. But for all diabetics, this is something which is very, very often missed, require a pneumococcal vaccine at any time. Whenever they are diagnosed, please advise a pneumococcal vaccine. Not just a pneumococcal vaccine, people with diabetes also require a flu vaccine annually. How many of you have had a flu vaccine this year, the last 3-4 months? Very good, at least the number of hands going up are much more than a couple of years back. So all of you as healthcare workers are at high risk, whether you have diabetes or not, you are at high risk of flu. So same way you need a flu vaccine and the patient requires an annual flu vaccine, And similarly, diabetic patients also require a pneumococcal vaccine, which is a polysaccharide Pneumovax 23, whenever they are diagnosed. After that, when they hit 65, then you need to give a conjugate and a polysaccharide vaccine. The fourth case is a 42-year-old diabetic who says that I dropped something on my leg about 2 weeks ago, and then I didn't bother about this, and he comes to you with what looks like a typical diabetic foot ulcer. Okay? So, I'm going to highlight a couple of things which very often we miss. The first question is, how do you culture a diabetic ulcer? Please do obtain an appropriate specimen from almost all infected wounds. Do not routinely take a sample. If you suspect it is infected, take a sample. Before you take a sample, cleanse and debride the wound before you obtain the specimen. Obtain a tissue specimen by scraping with a sterile scalpel or a dermal curettage or biopsy from the base of the ulcer. No point in swishing a swab on the ulcer. It will show all kinds of wonderful bacteria which may not be relevant at all. So please cleanse the ulcer base and then scrape it and send it for culture. Aspirate any purulent secretions using a sterile needle and syringe, and promptly send the specimens in a sterile container to the lab if possible. Please do not culture a clinically uninfected lesion. Obtain a specimen for culture without cleaning, or please do not obtain a specimen for culture by swabbing the wound or wound drainage. This is very, very important, because very often I see the initial swab shows an ESBL, they give some antibiotic and then again take a swab. This again shows bacteria which are now being selected out by the antibiotic, and that will grow something more resistant. So we need to give something stronger, and then we end up finally, giving a whole mishmash of antibiotics without properly taking the swab. The next question, which antibiotic would you select for a diabetic foot ulcer? In general, acute wounds are predominantly caused by gram-positive organisms. Chronic wounds or wounds for which you have used antibiotics will have gram-negative. That is what the conventional wisdom says. But before you do, is there a clinical site of infection is a question you need to ask. Do not treat clinically uninfected wounds. For infected wounds, as I told you, if it is acute, it is gram-positive. If it is chronic or prior exposure to antibiotics, or people who walk barefoot, require gram-negative cover. There are certain things, if they have had past history of MRSA infection or multiple boils over their body, think of MRSA. Consider gram-negative cover, as I told you, if they have been exposed to antibiotics. If there is exposure to water, if they are barefoot walkers with exposure to water, Pseudomonas is a high possibility. Consider this as empiric therapy. And also assess the infection status. Now, even though, as I told you, acute infections gram-positive, chronic infections or patients who have received antibiotics gram-negative, the Indian experience is slightly different. This is a study which came about a couple of years ago, and it was found that almost 75% of diabetic wounds were gram-negative. And this was also an experience from Turkey and other places, and they also said that gram-negative is a predominant fact, the etiology in most diabetic foot infections. And unfortunately, as you see, the resistance pattern, ESBL is resistant to third-generation cephalosporins, AMP-C is a mechanism by which the bug is resistant to beta-lactam, beta-lactamase inhibitors, and carbapenem resistance, all of which are rising. So no longer do we have the luxury of treating our patients with oral antibiotics, especially for a chronic ulcer or an ulcer which is not looking very good. We need to give parenteral therapy, and we are now relying more and more on beta-lactam, beta-lactamase, carbapenems, and something higher. So please be aware that only infected ulcers need treatment, and let us focus using appropriate antibiotics. The last case, a 35-year-old poorly controlled diabetic complains of facial pain and swelling on the right side of the cheek for the last 3 days. Looking quite innocuous, even though she says she hasn't slept for 2 days because the pain is very, very excruciating. For all such cases, please ask them to open their mouth and look at the palate. If there is signs of a necrotic palate or a hole appearing like this, I would say it's a death knell. In the sense that these are bad, aggressive mucor cases where, in spite of all the aggressive appropriate treatment, you may still end up losing the person. So how do you approach? Please remember that if you're looking at management of mucor, antifungals come number 3. The first step is to confirm mucor as quickly as possible, which means you may need to take a piece of tissue, look under the microscope and send it for culture to confirm whether it is broad aseptate hyphae. So the term for mucor by a microbiologist looking under the microscope is broad aseptate. It doesn't have septations, hyphae. That is mucor. You need to first eliminate the predisposing factor. So for a diabetic, you need to control the sugar as aggressively as possible. 2, you need to debride it. Mucor is an angio-invasive fungus. It enters the blood vessel and spreads very fast. So ensure that you remove as much as the infection as possible, if possible, the whole thing. And antifungals come number 3. About a couple of months ago, we had recommendations on the European guidelines on management of mucor. I just want to highlight a couple of things. They have categorically said, if you're able to see the last block on the right, avoid conventional amphotericin B. So, in fact, they have gone to the extent of saying that it is a negative, what do you call it, or a negative recommendation, where do not use conventional. But unfortunately, that is Europe. I don't subscribe to that. I still feel that because of limitations due to economic constraints or availability, we still have a role for conventional amphotericin B, but they advise only liposomal amphotericin B. We have now got isavuconazole, which is likely to come to India in the next 3-4 months, and posaconazole. The problem with posaconazole is very poor oral bioavailability. So you can give IV posaconazole, but the drug of choice would still be liposomal amphotericin in India, failing which we can give conventional amphotericin. We still don't know how long we need to give the drug, but make sure that the sugar is well controlled, ensure that you give at least 4 weeks of treatment, whichever you use, and then you need to decide on a case-by-case basis, depending on the sugar control, whether you can think of changing to oral posaconazole or stopping the treatment. So I'm going to end with this. If you're looking at prevention of infections, of course, Sriram said sugar control is not enough. We have to look at lipids, we have to look at all other things. I am a simple infectious disease physician, so I will stick to sugar control, lifestyle modification, vaccination, and periodic follow-up. And I found this was very nice. Diabetes, give it an inch and it will take a foot. Very true. So please remember that when you approach a patient with diabetes and an infection, you are aggressive about treating it. Thank you.
Thank you very much, sir, for your excellent lucid presentation. We got one question. Recurrent UTI, pyelonephritis, DJ stenting for papillitis necroticans, totally asymptomatic, persistent pyuria, significant colony count. Do we treat or not?
Nope. That's what I said. This is an asymptomatic bacteriuria, doesn't warrant treatment. I wouldn't even repeat a culture in a person who's asymptomatic, because other than adding to his stress and your stress, this is not going to help.
Nitrofurantoin and phosphomycin efficacy.
Right. Please remember, nitrofurantoin and phosphomycin, I'm talking about oral phosphomycin, are both recommended only for uncomplicated cystitis, not for pyelonephritis. These drugs, you take the drug, they go through the blood, go past the kidney without stopping and reach very high concentrations in the urine. So for pyelonephritis, they are useless. For uncomplicated cystitis, they are useful. 3 caveats for nitrofurantoin. 1, always use it only for uncomplicated cystitis. 2, please do not use it for prostatitis, because even though prostate goes beyond the kidney, it does not concentrate in the prostate, nitrofurantoin. And 3, both the drugs actually are worthless in patients with raised creatinine. If the creatinine goes less than 60 and definitely less than 30, they do not reach concentrations worthy in the urine. So please do not use both martifer or nitrofurantoin and oral phosphomycin in patients who have a raised creatinine.
The second question is, how common is herpetic esophagitis in diabetes mellitus?
I am not aware. Herpetic esophagitis is more common with HIV and AIDS, but specifically for diabetic patients, no major. Herpes zoster is more, a risk in diabetics, especially, recurrent herpes zoster is a problem with diabetic. But esophageal, you said esophageal herpes, no, not any specific relationship. Candida esophagitis, yes. So monilial or Candida esophagitis, yes, diabetics are at an increased risk.
Okay. Thank you very much, sir.
Thank you.